Welcome everyone to today's webinar, Chart Your Course to Recovery with Trusted Cost Accounting and Decision Support Tools, sponsored by Centellus Performance Solutions. I am Morgan Hafner from Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. It's now my pleasure to introduce today's presenters. Jay Spence is the Vice President of Industry Solutions for Centellus Performance Solutions. In his role, Jay focuses on shaping and executing the firm's software strategy, ensuring the Centellus Performance Solutions portfolio continues to evolve to address the changing needs of healthcare organizations. Jay has more than 25 years of experience working in the healthcare industry, helping organizations leverage technology to improve their financial management capabilities. Today, we also have with us Catherine Savage, who is the Assistant Vice President for Centellus Performance Solutions. Catherine serves as the practice lead for the Cost Accounting and Decision Support Implementation Group, with responsibilities for implementing costing and decision support software for client hospitals and health systems, and providing ongoing consultation. Catherine has 30 years of healthcare finance experience. At this time, I'm pleased to turn the floor over to Jay to begin today's presentation.
All right, Morgan, thank you for the introduction, and I'll thank Catherine as we get started for joining me today, and a welcome to everybody across the country. Good morning to some and good afternoon to others. My pleasure as well this morning to introduce you all to Centellus. Centellus was formerly Kaufman Hall Software. We today will focus exclusively on providing the most robust enterprise performance management software, data, and analytics platforms for our clients. And we are bringing together Kaufman Hall's Axiom software division and connected analytics capabilities that we recently acquired from Change Healthcare. So wanted to start with that bit of housekeeping news as well. So my role to get started is really just to kind of do some table setting around overall healthcare financial management today. And we can't really start this conversation without, introducing COVID. And if you walk your eyes around this slide, you're just noticing some, recent press that's come out and some studies around COVID. And you can't turn on the news without talking about it or hearing about it. And you could have easily titled this slide, instead of operating in uncertain times, we could have titled it Living in Uncertain Times. I think where many of us are in that stage where we're trying to get back to normal lives and kids going back to school, etc. And the right-hand side really highlights, I've taken a snapshot a couple of times of this and presented it, and it's looked different each time I've done it. And I think today, there's not a lot of green on there. I think there's been some surges in different parts of the country, which just really underscores that there's just a tremendous amount of uncertainty around COVID and its impact on our lives. And specifically, I think most of us on the call here today are finance people, healthcare finance professionals specifically. And I think COVID has introduced a tremendous amount of not only business and operational disruption, but certainly financial strain and impacts as well. There we go. I just got noticed that maybe I wasn't sharing the screen, so I'll start that again. So for everybody, I was just going through the current event slide here, so sorry if I didn't push that slide ahead of time. And just kind of reiterating the challenges around and the uncertainty around COVID as it's faced us in our everyday lives, and I was transitioning to this, which is really around the impacts that COVID has had on healthcare finance professionals and all the planning uncertainty. So I'm caught up now. So, there's just a lot of planning uncertainty around COVID right now, and I think it's also highlighted a lot of planning challenges that organizations have seen. Pre-COVID, and we've done this for the last several years, Centellus has done a CFO survey, and I'm going to let this build out. The CFO survey is a great way for us to get a pulse on the overall healthcare finance industry and how those organizations and those teams are feeling about their tools and their processes, what they have in place today to manage all that disruption. And if you look to the right, this is the survey pre-COVID. 9 out of 10 organizations said we're not doing enough to leverage analytics to drive essentially business decisions and inform our strategies. 3/4 of the organizations surveyed were highlighting the fact that they had resource constraints and there was a lack of efficiency in their planning processes as well. Almost 7 out of 10 organizations cited they don't have a reliable source of cost accounting and decision support analytics to inform their planning decisions. And then very telling, the top right, 8 out of 10 organizations said we don't currently simulate alternative views of our future. And when you look at all the things that COVID has presented us as finance teams today, we were really walking into this situation with maybe a lack of confidence in the current tools that we had. And I think those tools are going to continue to be incredibly important to advance, because charting that path forward is not going to be a blueprint that's the same for every organization. And I think organizations are going to really have to evaluate, as this slide really describes, where were we before COVID started in terms of our business position, our market position, our financial position, and what were the impacts of COVID? Were they significant on our business? Not everybody saw the same number of cases. And also when you start to look at the path forward, what opportunities are presented to us given all of the change that's happened? Do we have a chance to grow potentially and have growth strategies put in place? Is there restructuring or recovery that is needed? So really this is a slide that just highlights the fact that, recovery planning is going to probably take a different shape and form depending on kind of your current situation and your organizations. And it's going to require that you're doing a lot of very rigorous scenario planning and modeling to support kind of what that path forward is going to look like. So when we talk about recovery planning, for those of you who've seen some thought leadership coming out of either Kaufman Hall or from Centellus, you might recognize this framework here, the now, near, and far. It's been a really a digestible way to talk about what we do in finance every day. And the reason I highlight this is that the ability for us to analyze the business and plan effectively across these 3 time horizons has probably never been more important. And when you look at understanding the now and the near and the far, what we're really doing is understanding what's our current position today. And so we really require tools that give us that really strong feedback loop in terms of how we analyze the business and how are we performing today versus the near. As we start to look ahead and understanding our knowledge of today, what are the near-term strategies that we want to focus on? And how do we align our organization around those near-term strategies that are going to prepare us to essentially meet the challenges and the goals and the objectives that we have in our far and longer-term planning time horizon? So really the ability for us to manage now, near, and far, the tools in place to do this effectively have really never been more important. And what it really requires is probably more than ever, and I think as we have engaged with clients over the course of the last several months, I would say that this idea of having these tools working together in a very integrated and connected way is what has really been important. And if you look at the ability to, and I'm going to let this advance as we do it, the ability for us to really inform our longer range strategies, support how we align those strategies to our operational plans, and then to put the performance feedback and controls in place to understand, are we on track and where do we need to improve? So when we start talking about this broader set of capabilities coming together, how do we then analyze the business to understand, are we performing to plan as we expected? Where do we have opportunities to improve, to reduce cost operationally, to improve clinical outcomes and clinical efficiency? And the decision support capabilities that we'll talk about, which really help us broadly analyze the business and understand, what does this new normal look like for us in terms of our volumes and our service lines and our profitability and our cost and quality metrics, and bringing all that data together. And then finally, the ability now to more continuously monitor and reforecast the business, knowing what we know about how we're performing today and doing that with the rolling forecasting capabilities. So when we talk about kind of bringing together, topic of today, our cost and decision support tools, it's really bringing together a broader set of capabilities that let us analyze the business and plan more effectively and monitor our performance on an ongoing basis. So my last slide before I transition over to Catherine, cost accounting decision support just played such an incredible and important function, strategic function for organizations over the last several months. And a lot of what we're going to talk about today was the result of really feedback and discussions that we were having with various client roundtables and work groups that gave us a really strong feedback loop. And actually, I would say a really strong kind of point of view around how organizations were thinking about this process of preparing for COVID, responding to COVID surge and what was required of the organization operationally and financially, and then the recovery process as well. So we talked about prepare and respond and recover, and that was kind of a collective way I think our healthcare communities were talking about what they were going through, what they were facing. And I think when we start looking at each one of these, early in the process, cost and decision support became so critical to analyze the potential impacts. We were saying, what does a COVID case look like? And what does that utilization profile look like? What does that cost look like to us? How do we then simulate? We know that we're going to have electives coming off the line. We knew that early. For how long? And what will be the margin impact if we started to substitute the cases coming in for COVID through our elective population? And what is that going to look like? Over what time horizon are we going to be able to, are we going to potentially see that impact? And can we quantify that? And then the ability to monitor, as cases were coming in, to have a pulse on what's the case volume of cases that we're seeing around COVID, and what does that complexion of those cases look like? What does the demographic of those cases look like? And be able to put the right tools in place so that the organization can manage that, both operationally and financially. And then finally, as we start to measure, and I think many organizations anecdotally are coming back to a normalcy in terms of their volumes. Maybe it's a new normal, but a lot of the cases are rebounding. But being able to measure that as well, and cost and decision support becomes an important tool instead of capabilities to understand, where are we today, and how does that differ from where we were a year ago, or even 6 months ago or a quarter ago, and be able to have those analysis tools in place. So as I transition over to Catherine, I think the ability for us to really develop cost accounting and decision support capabilities are just so critically important for all of the reasons outlined on this slide, but also as they tie back to the broader planning activities that we're doing within our organizations. So Catherine, I'll hand the mic over to you.
Great. Thank you, Jay, and thanks to Becker's for hosting us today, and thank you to everybody for attending. It's kind of interesting to me. I mean, costing has always it's been a part of my career for a long time, and I find it very interesting, and it's kind of nice to have everybody else with the focus on costing now. These last 5 months, it's really become amplified, the need for accurate cost accounting information. So, I wanted to talk a little bit, I'll probably go into a little bit more detail around cost accounting, but I think it's important. The situation that we're in right now allows us to focus just a little bit more on the cost results itself. And, costing is something that's typically historical in nature, where we're looking at the time period that's just passed and what was the cost, the average cost calculation. But I think this has highlighted the pandemic and all that's going on here and our adjusting to this new normal has highlighted the need for it to be very proactive and the ability to react quickly. And I think about it in terms of not just this pandemic, but also other things that might happen in the future, regional competitive threats, things like this, where you may want to react quickly and adjust your costing model. So I like to think about this as a little bit broader than just this one specific situation. But the goal here is always around accuracy and reliability, and ultimately buy-in from your stakeholders. You want to make sure that the data is meaningful and that everyone is kind of on the same page as far as how it's calculated. So got a few things we're building out on this slide, and wanted to talk about some of the costing challenges that COVID-19 presented. And again, thinking about this specific to this situation, but it applies to a lot of things where you might have extraordinary cost, and so kind of working our way from the left to the right. Certainly we know that with the COVID-19 crisis, a lot of costs that we wouldn't typically see around testing and social distancing within the organization and creating those safe spaces for our patients. We incurred a lot of additional costs there. In addition, as Jay mentioned, the impact on volume was tremendous. And so a lot of reduction in volume but at the same time, increased costs, so costs that maybe weren't even specifically related to our volume, so it's a little bit out of sync. And how do we respond to that? And then sort of an interesting impact to me was the increase in cost and really the increased focus on overhead. A lot of this cost that we incurred is not specific to a patient population, although some of it was, related to the COVID-19 cases themselves, but there was a burden across the hospital, and we think of that as overhead, and not always our primary focus when we're doing cost accounting and analytics, but in this case, it's important to pay attention to it. And certainly within the organization, we had a lot of additional cost around facilities, supplies, equipment, the ventilators, providing that, again, that safe space, maybe even a new facility or repurposing existing facilities so that we had a place for the cases and wouldn't impact other cases. And then I think there's also this community impact where we're providing services for testing and other things within the community, so there's cost associated with that. So a lot of things that maybe weren't specific to a patient population, but nonetheless a cost that we incurred and a change in our organizational model. So when I think about this, not being the COVID-19 sort of impact, but I also think there's other things that are affecting our need for advanced costing solutions. And so kind of stepping back a little bit more big picture, and probably not saying anything that you don't already know, but healthcare is a very complex environment. So always has been and will continue to be so, and COVID-19 highlights that, and the ability to react quickly was important for all of us. And now as we start thinking about recovery and the modeling for that, there's complexity built into it just by its very nature. I think another thing that factors into advanced costing solutions and why they're important is increased physician engagement. So over the last, 10, 15 years, so much more partnership between hospitals and physicians requires more advanced methods, more transparency, the ability to communicate openly with your physician and collaborate with them. What we're looking for is efficiency and cost control. So I think that transparency is really important. So advanced costing solutions definitely will kind of move you in that direction. More source systems as inputs for cost modeling. This is, it's a double-edged sword in a way that we've got all this great data, and what do we do with it? And so understanding your data, being able to validate the data and then rely on it, not only as a part of your costing calculations, but as the reporting mechanisms and ensuring that all that great data is leveraged fully. And then sophisticated costing methods. Everybody's familiar with RCCs probably and RVUs. There are so many other methods that are available to us today. So with that technology and that knowledge, increasing the demand then for advanced costing solutions. So I think these four things are a little bit bigger picture, broader than just the COVID-19, but together it's a great opportunity for us to move our costing solution into a more advanced place. So I want to talk a little bit more about that, and I'll move on to this next slide and kind of highlight some of the features of an advanced modern costing solution. One of the things that I find to be really interesting, and as I said, I've been doing this for a long time, and so back in the day, cost accounting was really all around the CDM code. How many units of room and care code, and let's cost that out. Well, there's so much more. We've got physician billing and CPT code, so we can attach cost to that, and we've got health plans, and we may want to cost our members and the claims that flow through. So we've got the ability to cost completely across the continuum of care, and really anything that you've got volume associated with, you can cost it. So it broadens our whole perspective on cost accounting. Bottom left corner, encounter specific cost drivers. With the clinical definitions around patients, you're able to identify very specific populations, and so an advanced costing solution will allow you to cost very specifically, even if it's something that's recorded as overhead, really sitting off to the side, not in a patient care department, but you know which patients it goes to, and so maybe that's a COVID-related cost that you want to assign only to those COVID patients. Or maybe it's a cancer registry, and you've got that in a department that doesn't have patient activity, but we know the oncology patients that it's associated with. it's really nice to be able to associate that with the specific encounters and let that drive it. Top center, traditional and advanced costing methods, so we can bring all that together and we can pick and choose what makes sense for each specific cost item and cost category. So, you know, RCCs sometimes get a bad reputation, but they serve a valuable purpose for some of the costs that really isn't the most mission critical. Save the advanced methods for those situations where you get the most bang for the buck, so around implants and surgical labor and some of these things where you really want to be highly specific. Integrating with modern EMRs, as mentioned earlier, the data is king, and it's really what drives so much of our costing calculations now and the reporting. So we want to be fully integrated with our EMR. Top right corner, table-driven cost methods. So again, you know, if we know the vendor cost, let's assign it to the cost item. Right? Let's make sure that we're very specific with that. And not just the cost item, but how about the encounter itself? Let's go ahead and make sure that we've got the specific implant cost for that encounter assigned to that encounter. And so you've got full buy-in. When you start doing things like this and have that real transparency, I think then you can ensure that your stakeholders are in agreement with you and relying on the data. And that brings me to the bottom right, which is just transparency and traceability. A modern solution should not be something that's behind the curtain in the black box, so to speak, that you know everyone is able to see the full reconciliation, understand the process, and how we get to the end result. So there is no, not really sure how we got there, but you know the system says that's the cost per unit. That's not really a good answer anymore. So as we partner with physicians and our clinical leaders, that transparency and ability to trace the results is really, really important. So implementing advanced costing methods, I wanted to focus this slide a little bit more on data. It really is the foundation for everything we're doing within a costing process, as well as the reporting. But I wanted to focus on the cost calculation itself and sort of on the left side, thinking about the EMR and the source data. And I always like to simplify costing, even though I know it can be kind of complex, but it's really just your dollars divided by your volume. So fairly simple calculation, but we like to make it complex and factor in as many variables as we can. So, but if we stay focused on that simple calculation, we really have to be sure about the data that we're bringing in. So the EMR, you know, partnering with Epic or Meditech, Cerner, you know, some of those big ones that we're going to bring in all of that encounter data, again, for the cost accounting calculation, but also for the reporting. And so having a one-stop shop for your enterprise decision support solution and partnering, again, with the EMR so that we've got all the data, whether it's pharmacy data, surgical data, you know, whatever you need, all the imaging, everything in there in one place, enabling you to do the calculations as well as the reporting. Kind of build this out, and you see across the top we've got the encounters, you know, the calculations, the assumptions, the configuration within your system, and then the right-hand side is the actual engine in the Centellus, in this case, Centellus Axiom solution, going through the calculations, ensuring all the reconciliations and kind of proving it out, and then you've got results you can push back to your EMR, you can report out through the costing solution, the decision support solution. And so it becomes just this great flow of data, and if you're kind of following a few, what I think of as important principles across the bottom here, you're going to have great confidence in the results. And so I wanted to talk a little bit about this, that I call it a roadmap, so a game plan roadmap to address the high value areas first. And, you know, every organization is going to be a little different, but, you know, some of you will be highly focused on oncology, for instance. Others might be the surgical center. That's really your driving focus from a leadership perspective. And so you might want to focus on those areas first and make sure that that's where you're really putting the majority of your resources. I think also it's important to make sure you're not doing this in a silo. A lot of times, and especially with a big situation like COVID-19, this pandemic, and, you know, all hands on deck, it's good to have a cross-functional team come together to think about what needs to be done, what are our goals for the reporting, what is it that's most important in terms of the costing calculations. That enables you as a costing team to make the right decisions, adjust the configuration as needed. And then, as I mentioned earlier about data, so the third item I would just highlight is you want to make sure that your data is audited, validated, that you've got a good process for ensuring that the data is meaningful when it goes into the system, so that the results that come out are something that everyone will rely on. I think those three components are really important for us to manage as we keep the system, the costing solution moving forward. And it is a living, breathing thing that you're constantly going to be tweaking and changing the configuration as your organization changes and grows. And that sort of goes back to that statement I made earlier about healthcare being such a complex environment. It's constantly changing. I don't think it'll ever just be stagnant and dull. Never a dull day for us. Moving on to the next slide, I wanted to talk a little bit about planning for COVID-19. And now, of course, we're well into it, and for some, we're into a recovery phase almost. And we don't know that there may be another spike. There may be a longer kind of transition out of this over the coming months. But regardless, we want to have a plan. We want to think about what are we going to do and how we're going to adjust our costing solution to meet the needs. And I kind of like this phrase, measure twice and cut once. But I will say, with a modern costing solution, you can measure twice and cut twice if you really have to. You can't break it. It's something that we prefer not to go back and do it again. But you almost always can if you realize the results aren't quite what you want. So I don't want anyone to feel like you can't try something new and see if that works, because there are a lot of levers to pull in a costing environment. But I wanted to talk a little bit about these three items, and starting first with understanding how COVID-19 cost and revenue is recorded. And it's kind of interesting to me that a lot of times when Jay mentioned we've been having conversations with clients, and sometimes, and I found this to be true in my own experience with costing, that I was the last one to know where things were recorded. And it's just the nature of kind of the relationship between accounting and decision support and managed care and all the players that come to the table. So asking those questions about where they're going to record it, and ideally being at the table, having that conversation and where you think it should be recorded from a costing and decision support. So being able to kind of input your thoughts on that. But knowing where it's recorded, where the revenue is recorded is half the battle, because then you can respond and adjust the costing to reflect what needs to be done. Ultimately, looking to align cost with the activity. So understanding where the cost is really important. The second thing here in the middle is really around your reporting needs. So what we're going to do is we adjust our costing configuration, if at all right? We may not need to adjust anything, but if we do, understanding what is the end goal, what is it we're really trying to get at, and that might help us to know, hey, do we need a new cost category? Do we need a new kind of lens through some of these departments? Are they direct or indirect, and do we want to adjust how we're treating them through the cost processing? And do we really want all this cost to hit the COVID-19 cases, or does it need to hit some of the other cases? Because we can toggle with that. We can actually make some adjustments to ensure that the cost only goes to those cases that we want it to hit. And then thirdly, on the far right here, evaluating the cost option that best fits your situation. So taking all of this into consideration, and as Jay mentioned, really thinking about how hard hit you were as a region, as a community. I know some of our clients had very few COVID cases. They certainly saw the reduction in electives, but now they're back up to almost where they were before. So understanding that, and then thinking about what did the cost look like during those months? I mean, March, April, even May were just kind of brutal. And so do we want to factor those costs into our results and our modeling, or do we want to exclude those? So I think there's some things that we can look at, and in the next several slides we'll get more specific, but that's going to be important for you, is to evaluate your situation and how you want to respond to it. So I'll go through just a few points to consider, and it's funny to me that I'm starting with overhead, because it's not really anybody's primary focus. In general, it's kind of that afterthought. But in this case, so much of the cost really ended up as an overhead type cost. And so if you think about all the employee screening, the additional administrative costs, education, maybe temporary housing, all of these things, that's really feels like overhead to me. but you may want to push some of that directly to COVID cases. And so one of the thoughts that I have, and I think that you need to think about, is do we want a special cost category for this cost? And I would tend to say yes, especially this overhead cost. It might be a COVID overhead type cost category to contain that. That's going to allow you to turn it on and turn it off so that you can include it or not. Gives you a little bit more flexibility. So from an overhead perspective, I kind of like that approach. Again, you're going to have to think about your reporting goals and what you're looking to do, but I think this is an important consideration for all that overhead layer. We also had increased direct cost. So certainly those of you who saw a lot of COVID cases, you probably had a dramatic increase in PPE supplies, drugs, the ventilators, of course, all of that led to increased cost for your COVID cases. And I don't think we need to make this more complicated in any way. And so I would not encourage you to set up new cost categories. Make use of the drugs, supplies, labor that you already have. You're going to do your reporting at a service line level, and you'll be able to clinically identify those COVID cases and see the drugs and all associated with that. All that being said, if your organization really feels strongly about wanting to see specifically the COVID items, then you could create cost categories for each of these. And that's, again, one of the features of an advanced solution where you can easily add and remove cost categories as needed. The last element I'll mention here is related to the CARES revenue and other grants, other revenue streams you have that are not adjudicated, and so not at that patient level. But you want to maybe have that ability to offset the expenses, so you could treat that as an other operating revenue offset against your expense, and that way really kind of isolate it and get it associated with your COVID cases. Or you can leave it as a top-line revenue on your reporting, so it doesn't distort the actual cost, the expenses associated. So I can kind of argue both sides of this, but I tend to lean towards offsetting it against expenses, so you have a real net effect of what COVID did, and it reflects those revenues that you received. A lot of the clients that I've spoken with on this one have set up a specific other operating revenue category for this expense, so it really is easy to include or exclude, so that's something to think about as well. And then this last slide, I'll go ahead and just build it all the way out. It's a little bit, there's a lot on it, but I think this is an interesting conceptual slide, which is really, we did have some months that were a little bit, well, not a little bit, a lot out of the ordinary. So March, April, May really, really stressed our systems and created some unusual cost results. Again, very little volume, expenses were up. A lot of kind of mismatch in terms of what we're typically seeing in cost and activity. So when you're costing, you have the ability to cost year to date. So that top row is really reflecting that you would maybe cost January, and then you would cost February year to date, which would be January and February. And by the time you get to the end of the year, you've got all 12 months averaging out your cost. But for 2020, that doesn't feel right. It doesn't feel like a real accurate result. I guess it is accurate in the sense that it reflects reality, but it's going to be difficult to model from that. And so quarterly costing and monthly costing kind of gives you the opportunity to do this in smaller chunks, and you may want to remove that year-to-date feature and just cost on a periodic basis, and even take the months of March, April, May, or the second quarter or whatever, and pull it out. I mean, it could be something you use for modeling a future spike, but it may not be what you want to use to model the recovery period. So I think this is something really important. It's probably the most important piece, which is, how do we factor in those months that were so unusual, and how do we want to include those in our modeling? So I think that, you've got some options there, and I would encourage you to think about that. And again, the cool thing about costing is you can calculate cost sets that are, multiple views of the same time period, depending on the purpose and the use for those. So I like that feature in an advanced solution where you can really analyze multiple scenarios. And with that, I'm going to turn it back to Jay, because really all of this costing talk feeds into the next piece, which is the decision support reporting. And that's ultimately what we want. We want to be able to report and model and predict and plan for the next steps and the next months and years. So Jay, I'll turn it back to you.
Yeah, great. Thanks, Catherine. And, this discussion kind of brought me back to a couple of the first roundtable conversations that we had with our clients, and, how they were all asking that same question, how do we approach some of these things that are just extraordinary, right? We haven't had this ever happen to us from a costing perspective. So even the slide you were just on talking about almost every organization, most use the year-to-date method for costing, right? And that really wasn't appropriate. And so we started talking about some of those other features that we have around the costing of quarterly or monthly. And I also remember, Catherine, the discussions that we had from a roundtable perspective around how much cost do you push back just to those patients that had COVID? And you covered it well, I thought. The first reaction was, well, all that cost has to go right back to those patients. But when you really started to look at the cost and we really started to talk about it as a broader group, a lot of that was overhead. It was related to kind of keeping the doors open of the business, and it didn't necessarily relate to any specific population, but just what the business had to do, to keep the doors open, to keep people coming in. So really good discussion all around. So good stuff. So I'm going to transition and talk a little bit about some of the decision support reporting, and I'll just give a shout out to a colleague of mine, John Schul, who some of you on the phone may recognize that name. He's our Vice President of Product Management for Cost and Decision Support, and he really likes describing this slide. He's a long-time decision support and costing person in healthcare, and as I am. And, when you look at what decision support, as much as we've evolved in terms of costing and tools, I think this slide describes what we do in decision support really well, is that, we're acquiring data and bringing data in from all those different sources, just as Catherine has highlighted. And then we enhance that data, right? We bring all that information in and enhance it in really a unique way. I mean, cost accounting and decision support really plays that unique role in healthcare by moving us from that kind of organizational view of the business to a true line of business view. So we're attaching cost and reimbursement, and then we're organizing the data around different patient populations and service lines and cohorts as part of that. And then we need to be able to access that data. We need to be able to get our arms around it. As many of the folks on the call, I'm sure, are analysts, and you want to be able to kind of step into a tool and manipulate the data in different ways and analyze the results. So I think it's a great way to describe decision support, bringing in the right data, enhancing it, and then making that data actionable. So it was really interesting as we started to step into our COVID discussions with clients and helping them prepare. And I think they were informing us as much as we were informing them as we talked through it. And I think, Catherine mentioned it as I did. Each organization was, as we started talking, was kind of in a slightly different position in terms of what they were faced with. And so I think what I had highlighted before, I think is true. If you look at the reporting challenges right up front, organizations were, focused on using decision support tools to really evaluate those different financial profiles. We had to look at historical cases that matched up clinically from a diagnosis perspective with the COVID cases that we were expecting. But that was really important to be able to pivot and be able to get that information. So I knew what to expect from an organizational perspective, what kind of what kind of services and what kind of utilization profiles were those cases likely to have. And then we had some tools that we needed to wrap around from a monitoring perspective. I mean, were we seeing what we expected to see? And were we able to kind of do that, create that feedback loop that helped us really continue to respond as new cases came through the door. And again, as we started to think about that both financially and operationally. And then finally, we talked a little bit about the role of decision support. I mentioned this earlier around measuring lost revenue. That was the other, I think, major thing that we were focused on, is being able to kind of use this data and simulate and model, some of the business impacts, both what we had just occurred, but also looking ahead into the future. And I think Catherine said it well, and I'll agree with her. I think what COVID really required us to do more than ever was decision support had often been a tool that was used to look in the rearview mirror and determine, what actually happened and be able to analyze the past. And I think as much as ever, it was forcing us to use that information to inform our future planning. So just a few really quick call outs here in this area. I would say that the work that we did, and for folks who might be on the call who were participating in some of our roundtables or work groups or different communities around the DSS reporting, just really great job. A lot of good healthcare, a lot of good collaboration across that healthcare community, really helping each other out. But, the first thing we'll talk about is just evaluating those financial profiles and the ability to really look at these different patient populations. And from a tools perspective, ability to be able to essentially go in and query back those patients and analyze at a very detailed level what was that utilization profile look like, and be able to start to, as the patients come in the door, kind of evaluate that across those different slices of the data, different age categories and races. I mean, we started to see surges across different demographics and populations in that way, for sure. And so just the important role it played in that regard. I think the next piece was just that continuous monitoring. So one of the things that we talked about quite a bit is in terms of the source of information. While many organizations were relying on near real-time statistics that might have been coming out of their EMR, many organizations were looking to leverage the flexibility of decision support to load data really on an efficient basis. I mean, you can load data certainly commonly nightly or even more frequently than that, just to keep the system as updated as possible. And again, the ability to basically attach back the historical view of the business, but what's happening almost near real time was something that decision support tools became important for that reason. And so again, a variety of tools that allowed us to really look at things like mortality rates and the number of tests that were provided and the number of cases that were coming through the door with symptoms. All of those things became really, really important data points. And I go back to my current event slide earlier. There was a presentation that we did recently, and I think collectively we felt almost like we were getting to a good place earlier in the spring. And then summer we had that big spike again, and it's continued to kind of to boom. And so I think some of these monitoring tools are being used very, very heavily today, still, given all the COVID uncertainty. And the last piece, I'll just say, I think in terms of tools, what's so important is to be able to take that data and then model it. And so turn it in from a retrospective analysis to something that helps us plan for the future. So a lot of what organizations were doing was to just integrating that data right back into their planning and simulation processes. What does the future look like as we start to, understand what does this new normal look like? How is the volume and mix of cases different from pre-COVID? And what kind of trajectory do we have in terms of our recovery back to new normal? And I think Catherine suggests or said it earlier, we are hearing positive signs that organizations are getting back to near pre-COVID levels in terms of case volume and elective surgeries. And again, I think decision support has been just a really important tool set to be able to monitor that and then really inform that broader planning process. So as I start to close, this roadmap to recovery, I think I started at a pretty high level. I think when we talk about cost and decision support, it's such an important data source for us, but ultimately it becomes really important when the data becomes actionable. We can use it, especially when we start using it to inform our planning decisions. And then how do we use that data to manage the business as we move forward? And I think Catherine did a great job of talking about all the cost accounting kind of decisions that we needed to go through. And many of you guys are still working through as it relates to how do we handle those costs. So it best represents, basically the cost of those services to those patients and across those different service lines. And the first box really just highlights the importance of having an integrated team approach, really working together in a multidisciplinary team or a cross-functional team. To use Catherine's example again, you have to work closely with GL and the finance team and the payroll teams to understand how are things being tracked and captured. And the more that you can work closely with that team, you can inform maybe the best way to capture some of that information so that we can use it more effectively on the back end for some of the analysis and some of our costing work. I think middle box, when we talk about key stakeholders, I've also grown up many years in cost accounting and decision support, and it's just so important to be able to engage the different stakeholders across our organizations with cost accounting and decision support information. And I think we had a slide earlier that just talked about just the level of engagement that we are having as cost accountants across operational areas, with our clinical counterparts, and with the executive and leadership team as they start to use the data to guide strategy and financial decisions. It's just so important that those stakeholders understand kind of our methodologies and approaches and some of the decisions that we're making around our cost accounting data. And the next piece, I love this as well, the measure twice and cut once analogy. But I think it really is as much about being really thoughtful about the approach that you take to your cost accounting model. And I would say, as cost accountants today, broadly in healthcare, I think many folks are getting pushed out of their comfort zone a little bit. In other words, we do have modern tools available to us. There's more data that we can bring into our costing model. There's strategies that make sense in terms of how you start to take on the different initiatives to advance your costing approach. But the tools are there, and the data is there. And I think it's a measure twice, cut once. I think that's great. Like Catherine said, you could probably cut twice if you needed to. But I think as we close here, kind of a recommendation is to really be thoughtful about your costing strategy and continuously look for ways that you can improve on the accuracy. I think the old model of costing, where we wanted to get more accurate, always involved just a tremendous amount of extra effort and more resources to be involved. And today, what Catherine went over was a lot of ways that we can bring in new sources of data, increase the accuracy, but also increase the automation around all of those processes. So we can do both today. We can be more efficient in our costing, and we can also increase the accuracy of all the data that's coming in and the reliability and the trustworthiness of all that data as well. So just in terms of roadmap and to kind of sum it all up, just the integrated team approach is so important, getting stakeholder buy-in and involving folks in all the decisions, and then moving out of the comfort zone a little bit and trying some new things and really trying to advance the quality of data that you can deliver to your organizations. And I think that's all I had for remarks. And I think it's time for Q&A.
Thank you, Jay, and also Catherine, for that fantastic discussion. We'll now begin today's question and answer session, so please submit any questions you have by typing them into the Q&A box that you see on your dashboard. We're going to try to get through as many questions as we have time for today, and a lot of people are submitting some really great and thought-provoking questions. I'll start with this first one. An audience member is wondering, how do you categorize cases that are not true COVID-19 cases due to comorbidity? Does it fall as COVID or non-COVID?
Maybe I'll start with that, Jay, and then I'm sure you've got thoughts on it too, because I've thought about this a lot, and just in terms, I guess I'll kind of think about it in terms of service lines, just in general, that as I made reference to this in terms of how you're going to report on the cases, and ultimately you can create a specific service line for your COVID cases, and then that kind of gets to this question is, well, how do you know which ones to include? And I think there's some pretty well-defined clinical criteria around that. But ultimately, it's your decision around how you're going to structure your service lines and how granular you want to get as far as what falls into COVID and what's actually something else. But then COVID played a factor, because certainly a lot of cases where COVID maybe wasn't primary, but was secondary to something else. And so I think it's really ultimately how your organization wants to see it. But I was thinking about it in terms of, do you want a unique COVID service line, or do you want to break that out, as you drill into your existing service, medical service line? So, I think I've seen clients kind of going both directions with that, some wanting to keep it as a part of their standard service line structure, so you've got the continuity, others wanting to break it out as a unique service line, knowing that it may not be there permanently long-term. Not quite sure how long we'll be seeing COVID cases, to some degree. But I think it really comes down to, the goals for your organization and how you want to, classify it, whether it's primary or secondary as a part of that service line. I don't know, Jay, if you've got other thoughts to add to that.
No, it has come up quite a bit. I mean, I certainly think there are tools available in decision support that allows you to really break out, populations for analysis in different ways. And I think when we, you described that, and I think, those cases are going to generally fall into some of our traditional service lines. So I think that, you'll you have that traditional service line approach, and keeping that consistent is always good for reporting, and you still have a way to get at those cases. So I think you answered it well.
Excellent. And just a reminder to everyone to keep submitting questions. We have some really great discussions coming up so far. And this next one is about some limitations for just using RCC for cost accounting. And an audience member is wondering, what are the limitations of using just RCC for cost accounting, specifically for COVID-19 patients?
Yeah, and I'm going to say this isn't really specific to COVID cases. RCC has some advantages. It's super easy. I mean, it's just a default. You can do it without even thinking. But the trouble with RCCs is that it relies on the price of the cost item, your CDM code, to drive the spread of the cost. And price is not always a good measure of resource utilization. So as I said earlier, there is a time and a place, and it serves a great purpose when it's sort of some of those secondary type costs that aren't mission critical for your decision making. And so around COVID cases, maybe the overhead cost categories, you can use RCC to spread that. But I think that the risk when you start talking about, drugs and implants, which may not be specific to COVID, of course, but since they're typically not surgical cases, but I think then the risk is that the relationship is not really as accurate as you want it to be. So I save RCC for kind of those costs that are not as important, or when you're in a hurry, you're limited in your resources within the costing function. So I think there is a time and a place, and sometimes for an organization, RCCs is a quick way to get up and running, and then you want to get to something a little bit more accurate and reliable. So some of that standard kind of vendor cost associated, or markup for some of those costs. But I think RCC is a great starting point, but not where you want to be when it's the most important analytics that you're going to be doing.
And I think I'll just add, Catherine, the little discussion that you did around costing, the availability of data. We've got more data available to us now. We can use encounter-specific cost inputs, or encounter-specific drivers into the costing model, I'll say it that way. So we can bring that data in, and then the costing model can use that as the primary cost assignment method, and then you can basically use RCC for all the other stuff around that didn't get allocated through that assignment. So I think Catherine said it well. I think we continue to use kind of what we would say traditional methods for assigning cost, and RCC is certainly one of them. But I think, the availability of data now, we can get much more precise with how we assign cost to different patients. And I would go back to, I think, pick your spots, be strategic about how you take on surgical suite versus pharmacy and ER, and you just, pick those areas and really get a multidisciplinary team around attacking the costing and getting it more accurate in those areas, and then move on. I think that the challenge that many organizations have faced with costing, and this goes back for so long, is that you're just waiting for that perfect data to come out of the system. And that would be my only other recommendation. Don't wait for the data to be perfect, because you're always going to be tweaking it and evolving it.
Just some excellent insight. Thank you so much. And our next question is back to sort of categorizing the COVID-related overhead costs. So an audience member is wondering, when you say categorize COVID-related overhead costs separately, do you mean by creating a new cost bucket breakout so you can see the impact directly in reporting?
Yeah, absolutely. And I think this is when I was talking about an advanced solution, it's one where this is easy to do. It's easy to add a new cost category or bucket. And everybody's got different terms and all, but within Axiom, we talk about cost categories, and so having the ability to add a new cost category easily and remove it later when you no longer need it, right? So you might want to remove it in a year or two. But adding that category, and then what it allows you to do is decide, do you want to include that in your reporting? So it's easy enough to roll it in with some of the other overhead to actually, allocate it through the costing process, but you can also exclude it from your reporting. So if there's a desire to see the reporting without some of that extraordinary cost, it's easy to do. So being kind of thoughtful and methodical about what you include in that category, and then the ability to toggle it kind of on and off. I think that's the flexibility you're looking for.
Yeah, thanks for the clarification there, and great question as well. And we have another question about, how to map out your costing. So someone is wondering, do you recommend monthly or periodic costing given our unique year with the pandemic?
Yeah, I do, and I've started moving when back in my experience has almost always been to do a quarterly year-to-date costing, and the more I've thought about it, and especially during this time period, reflected on it, that I think a monthly view is better for trending as well as the ability to kind of exclude that cost when you want to.
Excellent. Next question is, what do you recommend for handling guaranteed physician payments?
Yeah, I think this comes back to the whole thing of, the physician payments that you're guaranteeing are there to support the entire organization. So I think it's important to think of that as overhead. That's the way I see it, as overhead cost.
Great, and we just had another question come back in about costing and when to do that. There were an audience members wondering how could we handle quarterly costing with year-end entries.
I know what you're saying. I mean, I think in terms of all hitting that fourth quarter. And, I guess that comes back. I always think about year-to-date costing because it allows you to kind of account for the fact that accounting doesn't always do things the way we want them to in decision support. So, that definitely is a challenge, the year-end entries, and whether you're going to spread that and go back and restate your earlier quarters, which is an option. You could spread that and then capture it in your earlier quarters, depending on what the year-end entries are. I think you have to kind of think through what the entries are, how material they are, because definitely they probably are not all going to affect, they're probably not all related to a fourth quarter. They're probably more affecting all 4 quarters or all 12 months. So it's a great question, and it depends on how large, again, and what they're specifically related to. Nobody wants to redo all the previous quarters of cost. I understand that. So.
Absolutely, lots to think through there. Next question is about solutions. Someone is wondering, which solutions do you consider advanced?
I can take that one. That's a term. That's a term we've used in the industry, I think, for a little while now. I think it's for many of us who've been working in cost accounting. Catherine, you tipped your hand too. In decades, right? We've been doing this. There was kind of traditional methods, right, that we've always used in the past, which were primarily RCC or RVU, and those were probably the 2 mechanisms that we used most often. Arguably, many of us got pretty creative even with our older systems that we were using for cost accounting, and we could do some pretty advanced things. But I would say today, when we talk about more advanced methods, it's a couple things. It's the ability to bring in encounter-specific cost drivers, so information that's coming in off the patient record, and being able to incorporate that really dynamically into the costing model. So the costing model recognizes those encounter costs, understands kind of how many dollars were attributed to that month related to those costs, and can offset that against the traditional GL data that we have, and then do that kind of math to understand what's that residual and allocate that accordingly. So that whole model, I think, is really where we use that term advanced. It's bringing in more encounter-specific data. But I would also say there's some things that we do, and Catherine mentioned it as well, related to pharmacy, like reverse markup is an example where sometimes that's an appropriate way to look at a charge. We know what the standard markup might have occurred, so we can use that as a way to establish a proxy cost that might be pretty accurate. Or other table-driven methods, like if we want to bring in a supply cost that we update, let's say, on a monthly or periodic basis, we could do that. So there's lots of things that we're doing now that are really allowing us to leverage acquisition cost and time and other table-driven methods to just make the system much more efficient and automated. So it's really a good question. The term advanced, I think, is an umbrella term for some of the newer methodologies and approaches that we have today in costing.
Thanks for breaking that down, Jay. And just want to give another thank you shout out to the audience. It's some really great questions today and awesome discussion. Unfortunately, we are out of time today, so I'm going to extend a final thank you to Jay and Catherine for their excellent presentation, and also Syntellis Performance Solutions for sponsoring today's webinar. So please enjoy the rest of your day, and we look forward to having you join us for future webinars.